Patients with posterior urethral valves are typically diagnosed in the prenatal or antenatal period. However, a subset of patients may be diagnosed later in childhood due to mild obstruction from their valve leaflets. To better define management patterns as well as outcomes of patients with delayed posterior urethral valve diagnosis, we compared post-ablation management and clinical outcomes of patients with infantile, which we defined as being diagnosed and managed less than 1 year of age, versus those that were diagnosed in childhood, which we defined as age 5 or later. And the reason that we did this is to gain insight into the pathologies at opposite ends of the PUV spectrum. We performed a retrospective cohort study using a large multi-center research network from 2006 to 2022. We defined 2 cohorts. The infantile arm were diagnosed and managed within 1 year of life, and the childhood arm had an index diagnosis and valve ablation after age 5. Our primary endpoints were looking at rates and time to first use of various bladder management medications, including antispasmodics and alpha blockers, as well as surgical interventions such as Mitrofanoff, Monti, and pterocystoplasty, as well as bladder Botox and CIC. Lastly, we also collected data about CKD, chronic kidney disease, and looked at rates of renal transplantation. We included about 600 patients in this study, 300 in the infantile arm and about 250 in the childhood arm, with about 10 years of follow-up in both arms. Not surprisingly, the younger arm, that infantile arm, were significantly more likely to have hydronephrosis seen on prenatal ultrasound, and that group is also most likely to develop neonatal sepsis. The childhood arm had a much greater heterogeneity in the presentation of their symptoms. Some developed new urge incontinence, nocturnal enuresis, hematuria, as well as urinary retention in an otherwise toilet-trained child. Following valve ablation, many of those patients in the infantile arm developed febrile UTIs and did so significantly more often than those in the childhood arm. Ultimately, the most common management strategy for both arms was antispasmodic medication, about 40% in both arms. Patients in the infantile arm were significantly more likely to be started on CIC, as well as undergo enterocystoplasty, Mitrofanoff, Monti, or secondary cutaneous vesicostomy. When looking at rates of CKD, we found that patients in the infantile arm had a roughly 2-fold increased risk of nearly each stage of chronic kidney disease, as well as a 10% rate of progression to end-stage renal disease. From these data, we can glean several conclusions. First, early medical management with antispasmodic medication was common in both patient groups, which is consistent with recent evidence suggesting that antispasmodics may attenuate progression of severe bladder dysfunction and compliance changes in patients with PUV. Additionally, patients with a childhood PUV diagnosis were disproportionately managed with more conservative strategies compared to their infantile diagnosis counterparts. But despite higher utilization of conservative strategies, the childhood arm had superior renal outcomes and low rates of progression to invasive treatments. So ultimately, when taken together, these findings suggest that a very late diagnosis of PUV reflects an overall milder disease process with more favorable renal outcomes.